Dear chairs, I'm happy to discuss new antihypertensive drugs now in my presentation. First of all, I show my disclosures and would like to start with the overview of the available classes of antihypertensive blood pressure lowering drugs. So we have fortunately many drugs available, different classes. We have 5 important first-line classes of blood pressure lowering drugs, including the renin-angiotensin system blockers, the beta blockers, the calcium channel blockers, and the thiazide-like diuretics. And there, in addition, we have other drugs such as alpha blockers and central sympatholytic drugs and other vasodilators. Clearly, the RAS blockers, the ACE inhibitors and the angiotensin receptor blockers, are representing the backbone of therapy in our core drug treatment strategy for uncomplicated hypertension, but also for other conditions. Nevertheless, the RAS system, as we know it, has expanded during recent years, and there are many other targets which are summarized in this quite busy and complex figure we put together a few years ago, highlighting in this text in red font potential new targets, new drugs targeting different pathways in the renin-angiotensin system. So with the red circles, I highlighted the available inhibitors of the renin-angiotensin system and also aldosterone system, basically the mineralocorticoid receptor antagonist. But as indicated with these blue circles, there are many other possibilities and developments, preclinical predominantly, but also clinical studies, such as for the APA inhibitors that have been pursued during the last 20 years. In addition to the RAS inhibitors, there are also other drug developments in the vasculature, such as vasopeptide inhibitors, Rho kinase inhibitors focusing on vascular smooth muscle cell, soluble epoxide hydrolase inhibitors, natriuretic peptide receptor agonists, vasoactive intestinal peptide receptor agonists, and clearly also drugs acting on the nitric oxide soluble guanylate cyclase SGC pathway, and also endothelin receptor antagonists. And there are also a few other mechanisms outside the renin-angiotensin system and outside the vasculature, targeting mechanisms that are also involved in blood pressure control, such as absorption of sodium, linked by the sodium proton exchanger 3 inhibitor, dopamine beta hydroxylase inhibitor, targeting central sympathetic nervous activity, and also special drugs have been targeted for the treatment of preeclampsia. And more recently, also the gut microbiome has been linked to blood pressure control, salt sensitivity, and therefore might also be influenced via drug treatment or therapeutic approaches. Novel drugs and targets delivered from genomics and systems medicine, including artificial intelligence approaches to identify new mechanisms and also new targets for blood pressure control, blood pressure treatment, hypertension treatment. On the other hand, there's a disappointing slide I show here summarizing between 1996 and 2011, paper was published in 2015, the overview of drugs that are in clinical development, meaning in phase 1 up to phase 3. And as you see, over time, there was an uptake and increase in compounds that are developed in the field of oncology and other disease indications, but cardiovascular lags behind, indicated with this kind of orange color here. At the bottom, there's a floor effect and less progress in cardiovascular medicine because it's felt, including particularly also hypertension, that maybe the unmet medical need is not so high, and that was even considered that the blood pressure treatment and the antihypertensive treatment, basically the book is closed, because with the available drugs was felt that they are sufficiently efficacious for the management of hypertension in clinical practice. And this also is related to the biomedical research overall, and also the hypertension research specifically. If you look into the worldwide increase in the number of original publications in the different fields, overall biomedical, cardiovascular, and hypertension, you see that hypertension, again, lags behind, and there's a risk that it falls behind even more so in the future. So there are only a few drugs with active clinical development in hypertension for several reasons. The reason for this is that the drug development within the clinical phase is usually not continued until the phase 3 stage with the final approval of the drug for hypertension, even though companies still use hypertension during early clinical development, and certainly also in the discovery preclinical setting as a test or proof of concept to test the efficacy of the drug, such as in hypertensive rat models. But they do not continue successfully until the end, but may deviate the development into other disease areas associated with hypertension, such as nephropathy or heart failure. And I'll show you one important example, which is the inhibitor, angiotensin receptor blocker, neprilysin inhibitor with sacubitril valsartan, the combination that has been approved for treatment of HFrEF, as we all know. But what is sometimes forgotten, that this drug is very effective for blood pressure lowering, as it has been shown in the preclinical and clinical setting up to the phase 2 study published in The Lancet 2010, and that clearly showed that the combination, the ARNI in green shown here, as compared to valsartan monotherapy, leads to a further significant greater blood pressure lowering, systolic, both systolic and diastolic. So it's a very efficacious blood pressure lowering drug, but nevertheless, it has not been pushed forward to a phase 3 trial and approval for the treatment of hypertension, because the clinical development was focused on heart failure only. And certainly this drug could be a very important and helpful drug to treat resistant hypertension, where we still have the first drug we recommend, preferred drug is spironolactone, the mineralocorticoid receptor antagonist, and certainly sacubitril valsartan could be also appears to be a suitable drug for treatment of resistant hypertension. But also other novel mineralocorticoid receptor antagonists would be seems to be attractive to treat resistant hypertension, because as compared to the steroidal mineralocorticoid receptor antagonists such as spironolactone and eplerenone, novel non-steroidal MRIs show a low risk for hyperkalemia and also overall better tolerability. Finerenone is another example, similarly to the ARNI example, that has been not developed for blood pressure lowering, but specifically for diabetic kidney disease. On the other hand, there's another non-steroidal MRI, esaxerenone, that has been successfully developed to treat essential hypertension, primary hypertension, in a phase 3 trial. As you can see here, as compared to eplerenone, the study was by design a non-inferiority trial. So the aim was to show that esaxerenone is at least as efficacious as eplerenone for the reduction of systolic blood pressure and diastolic blood pressure in patients with essential hypertension. And you can see here that this holds true. Numerically, it's even more potent in the developed doses of 2.5 and 5 milligram as compared to 50 milligrams eplerenone, but formally the drug was not inferior, so at least as efficacious as eplerenone, the non-steroidal mineralocorticoid receptor antagonist. So the drug was developed until phase 3 and also approved, but only for Japan, and it's not available globally for the rest of the world so far. While finerenone, the other MRA, has been successfully developed for diabetic kidney disease, and last year the Fidelio first phase 3 outcome trial in this condition was published, showing a clear benefit with an 18% risk reduction for the primary endpoint, as you can see in the slide. Blood pressure was fairly well controlled in this study, and overall there was a minor 3.2 millimeter mercury systolic blood pressure lowering effect as compared to placebo observed in this study. Nevertheless, when we talk about blood pressure lowering antihypertensive treatment in hypertension and patients with chronic kidney disease, we have clearly now two additional options that have also blood pressure lowering potential. One is finerenone, I just mentioned, and I don't go in the details in my presentation today, would be the SGLT2 inhibitors that have also clearly shown to be very effective and in the treatments of chronic kidney disease and are renoprotective and have also some blood pressure lowering potential. Coming back to the vasculature and the non-RAS options for novel antihypertensive drugs, there was much hope 10, 15, 20 years ago almost, when it started for supporting the use of endothelin receptor antagonists or endothelin converting enzyme inhibitors, but with disappointing results so far. Nevertheless, there's still a promising development ongoing with aprocitentan, a novel dual endothelin receptor antagonist that blocks both ETA and ETB receptor, both on the vascular smooth muscle cells, also having some effect on the endothelial cells, clearly. But the idea is that these drugs could be also efficacious and useful in the condition of resistant hypertension. And there's an ongoing phase 3 trial studying the efficacy of aprocitentan in this condition. And the study is estimated to be completed with the final results next year. Obviously, an intensive area of research is the analysis of the microbiome and its link also to the blood pressure control. There are promising, interesting studies linking it to salt sensitivity and salt-dependent regulation of immune response and blood pressure. And therefore, we can envision that a modulation of the microbiome, either by dietary factors, even also drugs, could also impact on blood pressure control and could provide an additional option for the development of new antihypertensive drugs. In addition, with the more than 1,000 independent blood pressure gene loci that have in the meantime been identified in the genome, and there are several other gene loci not identified yet because the heritability explained is only a quarter or so far. So by using, I think, basically the new developments in terms of systems medicine, artificial intelligence, analyzing the complex networks in blood pressure control will provide some additional novel targets for antihypertensive treatment. I would like to end with a very interesting and powerful approach also for blood pressure lowering, which is based on a new technology the small interference RNA, siRNA technology, that provides a possibility to target, for instance, within, again, coming back to the renin-angiotensin system, the important protein of this system, the angiotensinogen, so the precursor, large protein expressed in the liver, and that could be a target of a small interference RNA knockdown or suppression technology. We know this approach for several other diseases, also orphan diseases, but also in the cardiovascular field. The success story of inclisiran that is also using the same approach as siRNA suppression of expression of PCSK9 in the liver. And as you can see here, one injection of this compound, subcutaneous injection of this compound, can lead to a substantial, dose-dependent substantial reduction in the LDL cholesterol level as compared to the control placebo, with one single injection for a half year. So with two doses per year, this is a powerful LDL cholesterol lowering therapeutic approach that has recently been approved by the EMA in Europe. And that brings me now back to the antihypertensive treatment using this technology, and an important study, phase 1 study in humans, first in human studies, that has been presented as a late breaker abstract during our very recent ESH-ISH 2021 on-air conference on April 11. And this is a study about the safety, pharmacodynamics, and blood pressure effects of ALN-AGT, which is an RNA interference therapeutic targeting angiotensinogen. And that was a randomized single ascending dose study in hypertensive adults. And this study is based actually on a preclinical study, as it is usually being done, again, in the hypertensive rat models, where the group of Jan Danza from the Netherlands has, in a very nice experiment, shown that suppression of angiotensinogen expression in the liver by using the small interfering RNAs leads to a substantial blood pressure lowering effect in the hypertensive rat model. This is a mean arterial blood pressure. So these rats have systolic blood pressure about 200 or even higher. And by using, as highlighted with this box, this approach, a suppression of angiotensinogen expression with one single injection, you can see you have a significant lowering of blood pressure, and also an additive effect when you combine this approach with an angiotensin receptor blocker therapy, where you basically can substantially lower the mean arterial blood pressure in these hypertensive rat models. So this same approach was used now in humans, where specifically the expression of the angiotensinogen protein is being suppressed by a liver-specific silencing molecule using this interference RNA, which is designed to allow a very prolonged duration of action that allows a consistent, durable blood pressure response, potential for improved adherence, obviously, and also infrequent dose administration. And we have to see in the future how often that approach has to be dosed during the course of a year. And this is the slide they presented during our meeting. First of all, showing clearly that as compared to the placebo in a dose-dependent way, particularly with doses starting from 100 milligrams or above, substantial suppression of angiotensinogen expression levels as measured in protein levels in the serum. You can see that the primary endpoint was after 12 weeks, but yet the suppression, the high doses up to 800 milligram, lasts for more than half a year, almost 1 year here, a significant suppression. And at the very beginning, the first 3 months, the suppression is more than 90% of the protein. So that should lead to significant reduction in the renin-angiotensin system activity and also in blood pressure lowering, which has been shown in this study. Obviously, because this was a phase 1 study, the primary endpoint I do not show was tolerability and safety, and there were no severe side effects, so the tolerability was excellent. But we are obviously interested in the blood pressure lowering effect. After 12 weeks, just focus on the right-hand side. After 12 weeks, 3 months, you can see there's, as compared to placebo, in the 24-hour ABPM blood pressure analysis as compared to baseline, the substantial blood pressure lowering effect, again, dose dependent, more than 15 millimeter mercury in ABPM or average systolic blood pressure, and almost 10 milligrams, 10 something about around 10 milligram diastolic. So it's a fundamental blood pressure lowering potency with a single injection for how after 3 months detectable using this approach. So with this, I would like to end because I think there's light at the end of the tunnel and at the horizon for successful antihypertensive drug development, as highlighted by this very recent example of a using small interference RNA technology targeting the renin-angiotensin system. And I thank you very much for your attention, and I'm happy to take any questions that you may have. Thank you very much. Dear chairs.
ايه اللي احنا اخذناه من المحاضره اضافي بالنسبه لي؟ اولا دلوقتي بقى ريسيرش على ريسبتورز في الانتستين. الصوديوم هيدروجين انهبيتورز هيبقوا واحد من الادويه اللي هي بتحسن الهايبرتنشن. الليفر فيه بروتين معين بينتاجونايز، هيحاولوا ينتاجونايز البروتين ده اللي هو شغال على الرينين والانجيوتنسين. في بعض الادويه طلعت دلوقتي ريزيستنت هايبرتنشن، ودي جود نيوز، لان ريزيستنت هايبرتنشن ما بيمثلش كميه قليله من اللي احنا بنشوفه في العيادات بتاعتنا. في اكتر من معلومه، يعني انا يمكن نوت كاتشت كل اللي موجود. المينرال كورتيكويد انتاجونست بيتعدلوا علشان سبيسيفيك باثواي. الريسيرشز كلها بتتكلم على الريسبتورز، على مش الايتيولوجي، على الاوتكم بتاع الهايبرتنشن. بس ستيل لغايه دلوقتي مفيش حد بيدور على الكوز، السبب ايه. كل المحاضره موجوده على النيو دراجز. دكتور محسن تحب تضيف حاجه؟ طيب ننقل المحاضره الثانيه.